Okay, so let's start with gynae. First of all, we know that what are the different stages of puberty. We have all read it during our medical school, and what are the different stages, at what age they develop. So just for a flashback, just remember the names. We have adrenarche, in which the adrenal glands, they start secreting, and changes in voice, all these things start happening. Then gonadarche, increased secretion of gonadal sex steroids. Age is approximately 8 years. Similarly, thelarche, breast development, puberche, pubic and axillary hair development, and then menarche, onset of menses. And just remember that within 2 years or after 2 years of breast development, thelarche, mostly the girls, they do have their menses. So if they have thelarche at the age of 10, then at the age of 12, mostly they do go into their menarche stage. Then what is PMS, premenstrual syndrome? These are just the physiological and the emotional disturbances or the changes the girls they experiences 1 to 2 weeks prior to the menses. And once the menses are started, then within 4 to 5 days maximum, or usually with the start of the menses, these symptoms stop. What are these symptoms? There are two types. They can have somatic symptoms and affective symptoms. What are the affective symptoms? They are depression, angry outburst, irritability, anxiety, confusion, social withdrawal. Then they can present with some symptoms of pain like breast tenderness, lower abdominal pain, bloating, headache, pain in the lower legs, joint pain. They might also complain of some weight gain before the onset of menses. So these are all the symptoms of PMS. What we need to know is the treatment. A young girl, a teenager, or even in her 20s, they're presenting with these symptoms. What is the treatment? First line, second line is important for us, okay? Because we are always treating as a family physician in our office. We need to know till what level is our job. Next, at what level we are just referring the patient and our job is done. So whenever a girl is coming with the symptoms of PMS, we have to start with exercise, cognitive behavior therapy, vitamin B6, combined OCPs. And then if she has any symptoms of depression, irritability, anxiety, we can start her with low dose SSRIs. If they have given you in the scenario that the patient was started on combined hormonal contraceptives and she's presenting again after 3 months or later 4 months, or her depression has increased, sorry. So what will we do? Now we will move on to the second line of treatment. And what is that? We will move on to the IUS, levonorgestrel releasing IUS, and higher doses of SSRIs. We are only giving SSRIs if she has the symptoms of depression, irritability, mood changes. We see that, okay, then she needs SSRIs. Otherwise, just with some somatic symptoms or just with some somatic symptoms, so we won't immediately start her on SSRIs. So depending upon the symptoms, on the severity of the symptoms, we have to move. Similarly, we have premenstrual dysmorphic disorder. Remember, it is in this, mostly they will give you a married lady, older age, has some children, and now she's experiencing the symptoms of PMS. The symptoms will be the same, but on a higher level. More depressed mood, more social withdrawal, more angry outburst, irritability. These symptoms will be more pronounced. And what will we do? We have to at least 5 of the following 11 symptoms during the menstrual cycle in the last year. And the criteria is last year. And she will come to you and she will say, for the last 1 year, I'm having these symptoms. And before my menstrual cycle, the symptoms increase a lot. What are these? Depressed mood, hopelessness, anxiety, tension, affective instability, anger, irritability, decreased interest in activities, decreased concentration, lethargy, appetite changes, insomnia, overwhelmed feeling, and all these physical symptoms, joint aches and headaches. Now, already the patient is having these symptoms for the last 1 year, okay? So now what is the first line treatment? We will give her a symptom diary. Remember, if she's coming with symptoms for the last 1 year, they're giving you a scenario, a 30-year-old lady married with 2 children is here and presenting with symptoms of these PMS symptoms, somatic and other affective symptoms. And she's what is the next step you will do, or the next management you have to do? First, we will give her a symptom diary. We have to see how at what level her symptoms are. Okay, so for that, because whatever level her symptoms are, is already 1 year has passed and she has been suffering for those symptoms. So now our first step will be to give her a symptom diary, which she will use daily. She's gonna, whenever the symptoms are there before her menstrual cycle, she will write the symptoms in that diary, and then she will bring that back. And we will know according to that whether it is regular, what is the severity of the symptoms. And then after that, the management is the same. Hormonal contraceptives, IUS, SSRIs. But here the first line management is symptom diary. Similarly, then we should know about when we have to do ultrasound, when we have to do biopsy, when we have to do hysterectomy. So these investigations are very important. If you know when which investigation has to be done, you know, like gynae, the management, you know. Almost most of the ultrasound for most 3-4 cases we have to do ultrasound. Endometrial biopsy, we know what are the indications. First line, second line, we have to do that. So when are we doing ultrasound? We have two types. We have transvaginal ultrasound, and we have the other one is abdominal ultrasound. And if we are detecting a pregnancy, then in abdominal ultrasound, when the HCG level is above 6,500, only then at abdominal ultrasound, we can see a pregnancy. Otherwise, at transvaginal, we can even see when the beta HCG level is 1,500 or above. So if we want to confirm a pregnancy earlier, then what will we use? We will use TBS. Similarly, for endometrial biopsy, if the patient has abnormal uterine bleeding, she is above the age of 40, failure of the medical treatment, history of endometrial cancer, significant intermenstrual bleeding, and in women in infrequent menses, we are doing endometrial biopsy. But remember, it is not the first line. Okay, always first we are doing the medical treatment, we're doing ultrasound investigation. Only if there is a postmenopausal woman, they're giving you a scenario in which they tell you that there's a postmenopausal woman for the her last menstrual cycle was 5 years ago, 2 years, 10 years ago, and now she is presenting with some spotting or bleeding. First investigation is always endometrial biopsy. Postmenopausal woman with bleeding, spotting, even one time she presented, she said that I had spotting 6 months ago and now I am fine. We have to do endometrial biopsy, because postmenopausal woman with bleeding, until unless it is proven, it is endometrial cancer. So first investigation, we will do biopsy in them. Hysterectomy, it is the last resort in all these things, but it is not the first line indication, and we never write hysterectomy in any of these cases as the first line treatment. It will be wrong. Okay, so just remember, in the end, if any of these conditions are not treated with medical treatment, with other counseling, other infertility treatments, then the last resort, and it is very symptomatic, affecting then we move to hysterectomy. Otherwise, hysterectomy is not the first line treatment, and we always avoid doing hysterectomy, except for this cancer. Okay. Then we have amenorrhea. For amenorrhea, you should know this table. If you know this table, your life would be easy. What is amenorrhea? Absence of menses. It can be primary or secondary. Primary, never had it before. Secondary, she had regular menses, but now for the last 6 months, last 3 months, she is not having her menstrual cycle. So first, person is coming to you. First of all, we always have to take a history, do the physical examination. Then if it is primary, she never had it, a young girl at the age of 16, 15 coming to you, we will ask, did she have, we will check for her secondary sexual characteristics, development of breast, all the other pubic axillary hair, we will see whether they are there or not. If she says that, yes, my secondary sexual characteristics are present, but still she didn't have her menstrual cycle, then we will move on to the karyotyping. In karyotyping, we have XX and XY. In XY, it can be androgen insensitivity syndrome, and XX, the causes can be imperforate hymen, maybe a hymen is imperforate. That's why she's not bleeding. Transverse vaginal septum, cervix is not developed, or Mullerian agenesis, vagina, and some part of the uterus, they are not developed. So maybe some embryological causes can be there, which we will, of course, further investigate. Similarly, if she says that no, her secondary sexual characteristics are also not there, then we have to do the hormone level. What are these? FSH and LH level. If the FSH, LH is high, then we will suspect it is some gonadal agenesis or dysgenesis. And if low, it can be constitutional delay, it can be some HPO axis abnormality. Now for secondary amenorrhea. Whenever a woman of childbearing age is presenting with secondary amenorrhea, what are we doing? Beta HCG. Woman of childbearing age presenting with secondary amenorrhea, presenting with lower abdominal pain, presenting with pelvic pain, presenting with irregular bleeding. What is the first investigation we're doing in all these conditions? First investigation is beta HCG. Always remember this. If they're giving in a scenario, a woman with any of these things, we have the first investigation is beta HCG. Next, after beta HCG, if it is positive, of course, pregnancy. If negative, then we have to see check the prolactin level. The prolactin level are abnormal, they are high. It can be hyperprolactinemia, some tumor. So we will screen for that, and the patient will present with symptoms also. Maybe she can present with some thyroid symptoms, she can present with nipple discharge, some headache, visual problems. So we will further investigate that. Then we can do the MRI to check. For if the prolactin level is normal, what will we do? We will do the progesterone challenge test. If once the progesterone is given and it is stopped, if there is bleeding, we will check for the LH-FSH level. It means that everything is normal. Maybe there's some estrogen problem going on. So if it is high, most probably it can be PCOS, it can be the cause. If it is low or normal, what can be the cause? Any hypothalamus, pituitary cause. Maybe she's having some amenorrhea due to some nutritional deficiencies. Maybe she's an athlete. Maybe she's a patient of anorexia nervosa. So then we have to rule out all these causes. Similarly, if the patient has no bleeding, then she might have a primary ovarian insufficiency, or she might have uterine defect, Asherman syndrome, Sheehan, all these then come over here. We have to check them. After that, what do we have? We have the management. We did the investigations. According to what is it? We are doing the investigation. The same thing is they have explained over here. Similarly, for the investigation. Now, if the patient is of primary amenorrhea, karyotyping was done, and maybe she was XY, she has androgen insensitivity. Now, these patients are phenotypically female. From the parents, they will be female, but genotypically, they will be male. Now, what is the first line management? In these patients, always psychological counseling, because it is going to be a shock for them, right? A lady coming to you, everything normal, and you all of a sudden tell her that we are sorry, but you are genotypically male. You will not be able to conceive ever in your life. So it is a shock for her. So always first thing is psychological counseling. After then, these things come afterwards. So we will refer her for counseling and provide her with some social services. This is the first line. Similarly, if somebody has Mullerian dysgenesis, mostly in all of these, except for this imperforate hymen, first we have to counsel them. After the counsel, then we move on to the surgical treatment. And remember, if they are presenting to you with any of this, or they're telling you that these patients came to your office and after further investigation, she had an imperforate hymen, we are not doing the surgical management. We have to refer her to the gynae. Okay. Then for secondary amenorrhea, what is it? Either it is HPO axis dysfunction. We have to see what is the underlying cause and treat that. Then for hyperprolactinemia, what is the treatment? Medical treatment is cabergoline and bromocriptine, right? So we can start the patient on that. Then the resection comes later on, transsphenoidal resection. That is the definite treatment, but we can't just leave them for the surgery. They give the time for the surgery after 6 months. So we'll tell the patient for 6 months, we won't be giving you anything. No, we will start them on medications. And then whenever the surgery is done, that is done. So we have to remember the medical treatment also and the surgical also. And how do we confirm it? We confirm it with an MRI. PCOS, we will do it later on in the chapter. Then premature ovarian failure will also come, but we should know that in this, a young patient, maybe less than 40, she will present, or less than 45, she will present with symptoms of menopause. So we have to first check her FSH, LH level, and then we do have to screen her for any of these conditions. Diabetes, hypothyroidism, hypoparathyroidism. So this can be a CDM question. A patient, young patient coming with symptoms of menopause. What are you going to screen her for? So we have to remember, we have to screen her for diabetes. We have to screen her for hypothyroidism, hypoparathyroidism, hypocortisolism. Okay. Then hormonal therapy, we will give her the same which we give for postmenopausal women. Uterine defect, we have to check, do any HSG or SHG to check for any abnormality. That is also in layman, we call it the dye test in simple languages, the stereosalpingograph. Then Asherman syndrome, we have to excise the excisions, the patient, synecdoches. The patient might come to you and give a history of, like, she had a DNC done 4 months ago. And now for the last 4 months, she's not bleeding. What we have to do, we will do the hysteroscopy, and most probable diagnosis, they can ask what is the most probable cause. So it can be HMS syndrome. And what is the treatment? It is the excision of the synecdoche. Then we have this abnormal uterine bleeding. Now, abnormal uterine bleeding, it can be regular, it can be irregular. For regular, then we have to check, is it heavy or intermenstrual? Heavy, most common causes, adenomyosis, fibroids, some coagulopathy, endometriosis. Any cancer can also be there. Endometrial cancer can be the cause. And intermenstrual, polyps are the most common cause for intermenstrual bleeding. Then if it's irregular, is it for the irregular, the causes can be any ovarian cause, like PCOS, and then any menstrual causes. So we'll do it here. Okay, so remember this table. It is very important. Now for all these, polyps, adenomyosis, leiomyoma, leave this for the time being. So for these, even endometriosis, I don't know where yes, it was here somewhere. All these, the first line is TVS. We are doing ultrasound always. The first line investigation will be ultrasound. Okay. And either you're writing transvaginal ultrasound, transabdominal, it will be fine, but more accurate is transvaginal ultrasound. And then the treatment is, of course, according to the cause, but for treatment is almost the same also. We will do it topic wise. Then in malignancy, if less than 40, what are we doing? We have to first do the ultrasound, TVS, and if above 40, she's presenting with any symptoms of irregular bleeding, then we have to go for endometrial biopsy. But if mostly endometrial biopsy, we have to do first line in the patient postmenopausal with bleeding. First line is endometrial biopsy. Okay. Similarly, if there's some bleeding disorder, then we have to do some bleeding profile. They will give you a history of a woman presenting with heavy menstrual cycles since her menarche, and she even some relative, her mother had the same symptoms, or maybe she has a younger brother who has recurrent epistaxis. So we have to check for their coagulation profile. We have to do the von Willebrand factor. Maybe they have deficiency of Willebrand factor. Treatment, if very high bleeding, we can give tranexamic acid, then OCPs or Mirena IUS. Similarly, if there's some ovulatory cause like PCOS, so we have to do all these blood works. Endometrial cause, endometrial biopsy. but mostly they are talking about the endometriosis. So first line will be ultrasound. Okay, and the diagnostic is not endometrial. We don't go for endometrial biopsy, very last stages, and this is not our job. Iatrogenic, unknown cause, we will do all these things. Okay. Can you please mute yourself? Then depending on the cause, we will treat. Okay, so all of these conditions will come down, so we will discuss them over there. Similarly, for dysmenorrhea, what is dysmenorrhea? The patient is presenting with pain in the lower abdomen during the menstrual cycle, or it can start few days before the menstrual cycle. It can be now primary or secondary. Primary is before the menstrual cycle. When the cycle starts, the pain will stop. But in secondary, there is some underlying cause. Okay, primary is without any cause, and in secondary there has to be some underlying cause, and mostly it doesn't just stop immediately after the menstrual cycle has started. Okay. And the most, what is the diagnosis? The symptoms and the history. So how will we diagnose it? The patient will come with the symptoms, and she will give us a history. If there's no underlying pathology, nothing else, so most probably it is primary. And we are treating with heat massage and regular exercise, NSAIDs and OCPs. But if we do find any underlying pathology, we will on the bimanual examination, maybe the uterus is nodular, maybe the uterus is asymmetrical, it is bulky, maybe there is pain during the examination. So all these are the signs for some underlying pathology. Then, according to the underlying pathology, we have to treat the patient. Okay. So what do we have? This endometriosis. It is very important, very, very, very important. Endometriosis, what is this? It is just the presence of endometrial tissue outside the uterine cavity. Anywhere outside the uterine cavity, endometrial tissue will be present, and the patient with the onset of menses, she will present with pain and some other symptoms. Most probably, they will give you a scenario in which a female, she is presenting with infertility. And then they will give you a history where she has the symptoms of endometriosis. She will tell you that I have heavy menstrual cycles, I have pain during the menstrual cycle, and the pain lasts for throughout the menstrual cycle, even 2 to 3 weeks after that. So she will be present. They will give you the symptoms of endometriosis, and the patient will be presenting with infertility. Her major complaint will be infertility. What will be the cause? It would be endometriosis. Okay, and how will we treat them? Our first, we have to treat the symptoms of endometriosis, and then we will move on. Okay, whether she wants to conceive now, she doesn't want to conceive, then according to that, the treatment also changes. So what is the risk factors? Family history, nulliparity, and age more than 25 years. Okay, so these are the risk factors. Most common site is ovaries, where the endometrial tissue is present. We should know these DDs of endometriosis. What are the DDs? It is chronic PID, recurrent acute self-meningitis, chronic hemorrhagic corpus luteum, benign or malignant ovarian neoplasm, and ectopic pregnancy. Similarly, what are the most common symptoms of endometriosis? These. If she is presenting with dysmenorrhea, dyspareunia, dysgeusia, and dysuria, it is endometriosis, along with infertility. Even if not, she's not there for infertility, but she has these symptoms. She's coming to you and she's saying that I have dysmenorrhea. Along with that, I have pain while I urinate, while passing my stools, and what was the last? While sexual intercourse. So most probably our diagnosis should be endometriosis. So continue throughout and after the flow. Sacral pain with menses, like these are just the symptoms of the pain I just told you. Then infertility is the most common symptom. They will present to you with infertility. On examination, we will find tender nodularity of the uterine ligament, and they can give you that when you examined the patient, she had pain. Okay, there was tenderness. So it is one of the signs of endometriosis also. Investigations, gold standard is laparoscopy, but this is not the investigation we are doing at mostly it is a clinical diagnosis. Okay, but if they say that what is one definitive diagnosis or investigation you will do to confirm your diagnosis, okay, They're asking you one to confirm your diagnosis, then we can write laparoscopy. But otherwise, we will not say laparoscopy on the initial visit. The patient is coming with the symptoms of endometriosis. We will not say that, okay, next investigation is laparoscopy. We are not doing laparoscopy at the very first initial visit. They tell you that after everything we have done, the patient is with all the treatments done, now still she is not, her symptoms are not resolving. What is the investigation we have to do? Or they just give you the simple symptoms, and they in the next question they ask you the what is the single next appropriate or definitive investigation. Then we have to write laparoscopy. Okay. Then what will we see on laparoscopy? We have mulberry spots, chocolate cysts, powder burn lesions, early white lesions, and clear blebs, and peritoneal sockets. So you have to remember that these are the things which are visible on laparoscopy for endometriosis. They might give you a scenario where they are giving you the laparoscopic findings. And now what is the diagnosis? Or how will we treat? So just remember that these are the findings of endometriosis. Then if we are suspecting an endometriosis, on clinical findings, the patient comes with the history and we are suspecting it, the first line treatment is, we'll start with combined hormonal contraceptives, okay, or progesterone alone. Always start with OCPs. Like we will always start the patient with hormonal therapy. If the symptoms along with that, for pain, we can give NSAIDs and other symptomatic. But first, for endometriosis, the first line treatment is hormonal contraceptives. If it fails, we can move on to this one. And second will be progestin IUS. Okay, in second line therapy, do not write GnRH agonist like leuprolide. Okay, do not like that. First line, they said, okay, the patient came, we started her on combined hormonal contraceptives, but still her symptoms are not resolving. What is the next step? We will give her progestin IUS. Okay, this is the first, this is the second. Then after the failure of the second line, or we are done with the laparoscopy, still the diagnosis is not done, medical or surgical therapy, they fail, then there is something else. Or we have to consider another diagnosis. Maybe it is not endometriosis. There's some chronic pain management and all these multidisciplinary approach we have to take. Okay. So the symptomatic treatment is NSAIDs for pain, first line OCPs, then progestin IM, and Mirena IUS. This, if they are giving you OCPs, and now what is the second line? Then Mirena IUS or progestin IM. Don't immediately just jump after OCPs to GnRH agonist. We have to try all these. Then we will move here. And we are not even the one who are giving this to the patient. It is the job of the gynae. She will do it. So what are the leuprolide? What are the side effects of leuprolide? These are hot flashes, vaginal dryness, reduced libido. For if we are using for more than 6 months, then we have to add back progesterone or estrogen to prevent that osteoporosis. Similarly, we can give adenosole, but not very recommended. And the last resort is the laparoscopy. Okay, and if the patient is coming to you for infertility and she wants to get pregnant, then what we will do the conservative laparoscopy, and we will counsel her, and we always have to tell her that, okay, immediately after the laparoscopy is your best time to conceive. Okay, because at that time your chances of fertility will be high, so try to conceive at that time. So we do have to counsel her about that also. Then adenomyosis, what is this? It is just the extension of the uterine tissue into the myometrium. And in this, mostly what scenario they will give you? They will give you a multiparous woman with 3 or 4 births, age 40, late 30s. She's coming to you with the symptoms of irregular bleeding, dysmenorrhea, all the symptoms of adenomyosis. Okay, but mostly it will be an old age woman. It's not in young age women who have recurrent either cesarean section or vaginal deliveries, multiparous. Okay, always remember that. So they will have clinical features like heavy menstrual bleeding, secondary dysmenorrhea, pelvic discomfort, dyspareunia, dystasia, uterus symmetrically bulky, usually less than 14 centimeter, and Hellman sign is standard. softened uterus on premenstrual bimanual examination. Now remember, there's a difference between adenomyosis and fibroids on the basis of their examination, bimanual examination. Here, in adenomyosis, they might give you the same symptoms of fibroid, but they will give you the finding on physical examination that uterus is symmetrically bulky and enlarged. It might be enlarged, but it is symmetrically enlarged and bulky. In fibroid, it will be asymmetrically enlarged and it will be mobile. Okay, so this is the differentiating point on bimanual examination. Mostly clinical diagnosis. If they ask you for the investigation, we are doing ultrasound. Okay, ultrasound. Treatment, same. Heavy bleeding, iron supplements, NSAIDs for pain, IUS, Mirena, combined hormonal. Always we are starting all of these on combined hormonal contraceptives. If not working, then move to IUS. GnRH agonist, danazol, definitive it, hysterectomy. Okay. Fibroids, different types, and mostly in young patients, they will present with fibroids, or recently married or unmarried lady, and she's there with the symptoms of fibroids, some pressure symptoms. She might have some constipation, dysuria, might have pain during intercourse, or they may give you a history of a young patient with recurrent abortions. Okay, so these are all the symptoms of fibroids. And remember, if they are giving you any condition which is asymptomatic, we are not touching it. Asymptomatic fibroids, asymptomatic edema, anything that is asymptomatic, any condition that is not disturbing the patient, not affecting their lifestyle, we do not touch it until and unless it becomes symptomatic. In everything in medicine, okay? So if it is dysmenorrhea, heavy menstrual bleeding, they can present with the pressure symptoms like pelvic pressure, heaviness, increased abdominal girth, urinary frequency, urgency, constipation, bloating, retention, or present with the symptoms of torsion, acute pelvic pain. In that, they will present in the emergency department with symptoms of very acute pain in the abdomen and giving you a history of fibroid. So what is the most common cause? It will be fibroid torsion or degeneration. So we will do the ultrasound, we will check it and treat accordingly. For that, of course, it's going to be the surgery. Then infertility, recurrent pregnancy losses, or any pregnancy complication that can be there. Bimanual, whenever a patient is presenting in pregnancy with fibroids, we do not treat them. Okay, in pregnancy, we do not treat the fibroids, we do not touch them because they are highly, the blood supply is very high blood supply. So if we treat them, try to resect them or anything, they can be massive bleeding, leading to death. So we wait for the pregnancy, and after pregnancy, we will treat them. For on bimanual examination, what will be fine? Uterus asymmetrically enlarged and mobile. This is the differentiating point, okay? Then they can present with anemia because of the heavy bleeding. We have to treat them, ultrasound to confirm the diagnosis and assess the location of the fibroids. If the patient is only if symptomatic, we will treat. If the patient on accidental finding, we see that patient has fibroids, we did ultrasound for something else or any other bimanual examination and found the patient has fibroids, but she doesn't have any symptoms, no complaint, we will not touch it. Because after menopause, they already regress themselves. So we will wait until there is some symptoms, then we have to treat. Conservative management, absent symptoms or minimal, fibroid less than 6 to 8 centimeter or stable in size. Then just the recurrent follow-up, okay, just to check if she is having any symptoms or no. Then what is the first line for pain? We are giving ibuprofen, analgesics, NSAIDs, heavy bleeding, tranexamic acid, combined hormonal contraceptives, IUS, Depo-Provera. Then GnRH agonist, very late. Ulipristot is not available in Canada, so they won't give you and they won't ask you, but just if you want to remember, then you should remember it where we're using it. If the patient is here and she wants to conceive and she's not able to conceive because of the fibroids, what is the treatment? The treatment will be myomectomy. Never a hysterectomy is never the always myomectomy, because she's a young patient, she's not able to conceive, we have to treat her. Or if the symptoms are very like they are affecting her life and her symptoms are not being treated with the medical therapy, she wants to retain her fertility, she wants to conceive later on in life. So what is the treatment? We are doing myomectomy. Okay, surgical approach is myomectomy, and that's avoid on during pregnancy. Then we have contraception. Contraception is very important. You should know, we know that there are different types: combined, hormonal, then transdermal, contraceptive ring. Before starting, what we have to do, the OCPs, there's a 21-day pack or a 25-day pack. After that, there's a pill-free period, or we have the placebos, which we use. And that during that time, the patient bleeds. Then we have the patch. We change it every 3 weeks, and then 1 week, the patch free. Similarly, there is a ring which can be used. And what are the things we have to do before starting the patient on the OCPs? We have to take a proper history. Maybe what if they are contraindicated? We have to measure the blood pressure to check maybe the patient is hypertensive. Pelvic examination is not required, as STI screening can be done by urine. So we will take a urine sample. And Pap smear screening does not start until age more than 25. So remember, if a young patient or a teenager is coming to you for OCPs, in the examination or the test, we will not write any Pap screening. What are we screening her for? No, we are not writing Pap smear, because it has to start after age 25. And for STIs, we just do the urine analysis. Proper history, even that is going to help us. When do we start? At the 5th day of the cycle, and follow up in 3
I
months.
have a question.
Yes, I'll take the questions in the end. Okay. And
Okay.
you can write it in the chat if you forget it, so that I'll also check the chat in that. And okay, we'll do the question answer session in the end. Now, what are the remember what are the absolute contraindications? You will know then the relative also, and these are drug interactions. Okay, because they can give you and always remember, migraine with aura is a relative contraindication. A young patient coming to you, or anyone, she's coming to you like less than 30, she wants contraceptive, she gives a history of migraine with aura, we can start her in the CDM question. They are giving you options, or different types of contraceptives in which there is OCP, in which there is IUS, all the other forms, or they're just asking you to write what contraception we are going to give her. So remember, migraine with aura is not an absolute contraindication until unless the patient has some neurological symptoms. This is very confusing. Mostly the doctors forget it and they confuse it. So we will give her OCPs. Now, when the patient is started on OCPs, she presents with worsening of the symptoms, then we will stop it. But if the symptoms are not worsening, she has no neurological symptoms, she just has migraine with some aura, we can start her on OCPs. But of course, we monitor her, we counsel them, we tell them. Similarly, if the hypertension is controlled, we can give them OCPs. So these are the things you should know. Remember, if they might give you a scenario where a patient of 36 years, she is smoker, and is here for contraceptive counseling or asking for OCPs. Sometimes we forget, but smoker above age 35, contraindication, we will not give her. So just remember, any previous history of any DVT, we will not give her. So remember these absolute contraindications, they are very important. Similarly, if the patient is on any one of these drugs, then we have to increase the dose. Then they won't be effective. Okay, drug interaction is with rifampin, phenobarbital, phenytoin, graciofulvin, primidone, and John Ford. If they're taking any of this, the efficacy of the hormonal contraceptives will decrease. Either we increase the dose, we tell them that you need another contraception along with it. You need another barrier method. You need a backup method because you're taking these drugs. So these hormonal contraceptives won't be enough for you. Next, we have progesterone only method. They are used when we have POPs, IUS, Depo-Provera, Nexplanon, these are all the different methods. When are they used? You should know the advantages, disadvantages. Like if a pregnant woman breastfeeding, we can give them. They do not affect the breast milk. And similarly, IUS, they prevent in less bleeding if the patient is presenting with bleeding. So most probably, or they have some contraindications for the hormonal method, we can start them on any of these, depending on her preferences, on her compliance rate and everything. Nexplanon, it is an implant which we give, and it is expensive. Okay, so we have to always check the resources of the patient also. If a homeless girl is coming to us and asking, or even if a teenager is coming to us and maybe she's not compliant with her medications because she's homeless or a teenager, they forget, they just tell you that I'm not compliant with my medication. We can't just prescribe her Nexplanon. Okay, it's very expensive. So what can we do? We can give them IUS. We can give them IUD if no contraindication. We can give them Depo-Provera if they are non-compliant with the medications, or they have some other issues like a mother bringing in a child, a female who is wheelchair bound. She cannot take the medication. She's dependent on others. Anyone with cerebral palsy, any other such condition, then we have to, we can't just say that, okay, we can give them Nexplanon. No, we cannot. It is very expensive and not regularly even used in Canada. So try to choose from these two, either IUS or Depo-Provera. And mostly if she's wheelchair bound, so we will give them IUS, okay? And we should also remember, they can give you a question where they ask you that the patient is on Depo-Provera. She's trying to she stopped it last year or 6 months ago. She's trying to conceive, but she's not able to conceive. So we have to counsel them, tell them that restoration of fertility may take up to 1 to 2 years. Whenever starting them on any contraception, we have to counsel them and we have to tell them what are the fertility restoration time. For OCPs, it also takes at least 6 months. For progesterone, IUS, immediately. Once you stop it, the patient will be, she will be immediately, her fertility, she will restore it. So you should know which is having the longest time for fertility restoration, which has the lowest time according to the scenario. We have to counsel them on this. Then for IUS, we have two types, either the progesterone releasing Mirena or the copper containing. Okay, so we should remember this copper containing, we are also using it as the emergency contraception. Okay, for the emergency contraception, we in IUS, we are just using the copper one, not the progesterone one. Remember that. Then there are some contraindications we should know. For both of them, any pregnancy, they're pregnant, of course, we want any history of Wilson disease in patient with copper. We will not give them copper IUD. Any in STIs, the IUDs are contraindicated. History of PIDs, they are contraindicated. Female with high sexual behavior, in those they are contraindicated because they have high risk of STIs. So in all these conditions, they are contraindicated. We should know these. Similarly, what are the side effects of copper IUD? Increased bleeding and duration of the menses, dysmenorrhea, progesterone, headache, acne, breast tenderness, nausea, headache, ovarian cyst formation. They can give you a scenario in which they will ask you that a female, for example, with fibroids, okay, she is having heavy menstrual bleeding and she's not compliant with the OCPs, or even with OCPs, her bleeding is not stopping. So what is the next management we will give? We will give her progesterone IUS. Do not confuse. Copper is increasing the bleeding. So any woman presenting with a history of increased bleeding, any with increased blood loss during the menstrual cycle, we will not give them. If you have to give IUS, we are giving progesterone because it will minimize the bleeding also. Okay, it will help in bleeding also. So never give them copper IUD. It increases the bleeding. Also, they might give you a scenario in which they're telling you that a patient is coming and she got her IUD inserted 3 months ago, and now she has a complaint of irregular bleeding or heavy menstrual cycle. What is the next step? We have to counsel her. We will tell her that up till 6 months, it is normal that your menstrual periods will be irregular or they might be heavy. So up till 6 months is normal. We will wait and watch. After 6 months, if it continues, then we have to either remove the IUD or look into the underlying cause. Similarly, if the patient is taking OCPs and for the first 3 months, irregular spotting, irregular bleeding is common. And after 3 months, if still she has irregular bleeding or spotting, either we increase the dose of the estrogen. If still not working, then we can move on to any alternative method. Then follow up and check what is the underlying cause. Still, she is having irregular spotting or bleeding. But if they just started on any of these and they are presenting within 3 months of OCP taking irregular spotting, then just counsel them. We have to wait and watch. If no, then move on to the next step. For IUDs, always do the cervical swab for gonorrhea and chlamydia prior to insertion to check for any STIs. Then we did this in the family medicine. We have either the plan B given in 2 doses, 12 hours apart. More effective is IUD copper. If they are giving you a scenario in which a female is coming, a girl is coming, asking you for emergency contraception, both of them are in the MCQs, then we have to choose copper IUD because it is 99% effective, even given if within 7 days. If after giving IUD and the emergency contraception, she is not after within 21 days or 3 to 4 weeks, she did not bleed, we have to do a beta HCG. We have to counsel her to come back and do her pregnancy testing. Similarly, we have to give them, counsel them about contraception, to regular use them, tell them about the barrier method, tell them about the hormonal methods and the follow-up. Then we have termination of pregnancy. In termination of pregnancy, we discussed this yesterday, and I think I told you there is no legal age of abortion in Canada. If they want it, we have to do it. If we cannot do it, we have our own personal beliefs, refer the patient. Now, there are 2 types. Either it is medical or surgical. So if they are presenting with the gold standard age is 9 weeks. Like it is considered the gold standard time period, the best time to induce an abortion, 9 weeks. What do we start the patient with? Mifepristone and misoprostol. If the medical therapy fails, then what will we do? We will move to the DNC. Okay, and this is we are giving mifepristone and misoprostol less than 14 weeks. If they are coming after 14 weeks, then we have to start them on misoprostol followed by oxytocin. Less than 14 weeks, these 2. After 14 weeks, misoprostol and oxytocin. If the medical therapy is failing, we are moving to DNC. If they are less than 14 weeks, what do we do? Vacuum aspiration. More than 14 weeks, we do dilatation and evacuation. Just remember these names. Less than 14 weeks, it is aspiration. More than 14 weeks, it is evacuation. Then whenever a patient is coming, we discussed this before also, we have to counsel her. First, we will counsel her. We will ask her why she doesn't want to carry the pregnancy. We will give her different options. And after that, if she still doesn't agree, she wants to continue, we will go with her wishes. And we always, they might give you a scenario in which they tell you that a young girl, a teenager is here, she's pregnant, she's 9 weeks or 12 weeks pregnant, and now she doesn't want to carry the pregnancy. She did not disclose it to her family members, to her parents or her friends, and she just want to get rid of it. So what is our job in counseling? We have to counsel her that, okay, we know you want to go with the procedure if she doesn't want to continue it, but we do also have to counsel her that at least try to tell any one of the family member. Try to talk to your parents and take them into confidence and tell them, because this is a procedure, or any of your friends. Okay, if she says no, because this is a procedure which can carry its own complications. Okay, so we have to try to counsel her that try to involve your family or your friends in the procedure, any of your sister, any of your close relative, and then we will move on. This is also a part of counseling which we should know. They might give you a question regarding to it, an MCQ in which it can be one of the option, it can be a CDM question. So you should know this. Then what are the pregnancy related complications? They can be miscarriages or abortions. They can be of different types. First of all, always, now she's presenting with bleeding, amenorrhea, bleeding. First thing we are doing, beta HCG. They tell you beta HCG is positive. A female is presenting with bleeding. We did the beta HCG. The beta HCG was positive. What is the next step? Next step is ultrasound, either abdominal or TVS. They said, okay, ultrasound is done, pregnancy is confirmed. What is the next step? We will do CBC, but important, blood group and screening. Okay, they did not give you the blood group. So what is the important next step? It is blood group and screening. We should know the blood group. What if she needs some blood? Or if they haven't give you, because they haven't give you the blood group also, so you don't know her whether she is negative, positive. So we will give her ROGAM. So stepwise approach is very important. Treatment, depending upon the type of bleeding, if she's going in shock, we have to give her IV resuscitation. Remember this chart. Okay, if you know this, then you know the type of because in this they will not give you, they will give you bleeding, cramping. On ultrasound, they give you all the findings and they will ask you what type of abortion is it. This can be the MCQ question they're asking you. So they have given you a list of all these 3, 4, 5, A, B, C, D, E, F. And now on the basis of the clinical findings, they've given you all the findings. Choose one. So if you know in threatened abortion, there's bleeding and the fetus cervix is closed, the patient may present with some spotting, she's pregnant, and on examination, cervix is closed, the fetus is live, then what is it? It is threatened abortion. And what do we do? Wait and watch. Similarly, for inevitable bleeding and cramping, rupture of the membranes, fetus low in the uterus, on ultrasound, cervix will be open. We are doing waiting, not immediately we are treating, we are waiting and watching. They may progress to complete abortion themselves. Then we will give, if not, we will give them misoprostol and DNC if required. Similarly, in incomplete bleeding, cramps, with or without passage of tissue noticed, residual tissue in ultrasound, in the uterus on ultrasound, and cervix will be open. Same treatment like the above one. Complete, there will be, the cervix will be closed, no bleeding, the uterus will be empty, and complete passage of the fetal sac, the product of conception, everything will be passed, and there will be no bleeding. So no management needed. Just follow up. Similarly, in MIST, it is fetal death in utero. What do we have? No heart rate, and then we have to counsel the patient. The baby has already died, and after that, we give them the options of the medical treatment and surgical. Okay, so in this missed abortion, if they're giving you that on ultrasound, the fetus, there was no heart rate, the fetus has died, the mother presented to you at 12 weeks, 20 weeks, whatever. So what is the first treatment? We have to, they're giving you different options, then we have to write counseling also. Okay, we have to counsel the family, we have to provide them with some social support, because it is a very traumatic situation for the parents. The treatment will come later on. First, we have to counsel them. Recurrent, most probably it can be due to some antiphospholipid syndrome or some other like fibroid. But mostly if more than 3 consecutive spontaneous abortions, then we have to rule out the underlying cause. And if they give you, they might be asking you about the antiphospholipid syndrome. Septic, presenting with foul-smelling discharge, high-grade fever, tissues in the uterus on ultrasound after abortion. After a few days, they might present with all these symptoms. Or she was delivered at home, abortion happened at home, or she is coming from some rural area where it was done, and now she has all these symptoms. So maybe it is septic abortion. We will give them antibiotics, DNC, and misoprostol. Okay, then we have ectopic pregnancy. What is ectopic pregnancy? Ectopic pregnancy is embryo implant outside the endometrial cavity. Any woman presenting with abdominal cramps, bleeding, and what was the one more thing I forgot? Yes. So that is ectopic pregnancy. Okay, yes, positive beta HCG, abdominal pain, and vaginal bleeding. So these three things are present, it is ectopic pregnancy until ruled otherwise. What we will do, the management, it depends on whether the patient is hemodynamically stable or unstable. If she is unstable, we will proceed to the laparotomy and surgery. But if she's coming and they will give you a scenario, 7 weeks old, a pregnant lady, she's here now with, or 7 weeks, amenorrhea, irregular menstrual periods, and now she's here with vaginal bleeding and abdominal pain. Next step, we did beta HCG, it was positive, and now vitals are normal. What is the next step? Then we have to do TVS. Okay, after beta HCG, we are doing TVS. Now in TVS, if it is intrauterine, that is fine. But mostly for ectopic pregnancy, what we have to do, we have to see whether the patient has to be treated medically or surgically. So if she is hemodynamically stable and she is good to follow up, there's no fetal heartbeat, her vitals are normal, everything is normal, there's no rupture of the ectopic, then we will move to expectant management. If the ectopic is less than 3.5 centimeter, there's no fetal heart rate, beta HCG level is less than 5,000, no contraindications to methotrexate, no bleeding disorder, no hepatic or renal problem. She is compliant with her medications, she has no mental illness, we will move to give her methotrexate and follow her. If any of these contraindications to methotrexate, non-compliant with medication, any other underlying cause, she cannot be treated medically, then we have to move to the surgery. Okay. The risk factors of ectopic pregnancy, what are those? Previous ectopic pregnancy using IUD, PID, STIs, so there can be many causes. All of these are risk factors. You should know the DD, that is low urinary tract infection, UTI, kidney stone, diverticulitis, appendicitis, endometriosis, PID, fibroid, ovarian, all these are all the DDs. Because they can ask you what are the DDs. So you should know 2, 3, at least 4, 5 DDs of each scenario. After this, the treatment, we did it in conservative, same. Maintain hemodynamically stable, surgical is laparoscopy. Then if not RH negative, we are giving ROGAM. If they have not, in the scenario, they have not written anything about the blood test, even then we have to give them what is the next management step, we have to give her ROGAM. Always remember, if they have not given a ROGAM in a woman coming with bleeding, pregnant woman with abortion coming, any of these things, then we have to give her ROGAM. No history of ROGAM, we have to give her, of no history of blood group, we have to give her ROGAM. They are looking for this answer. Same, then medical, then we will follow up, regularly monitor their beta HCG levels. Then we have infertility. For infertility, what we need to know is that a couple is coming to you for infertility. We won't just start, we will jump to all the investigations of the female. If the couple is coming to you for the first time, then the first investigation, and they are fulfilling this criteria, okay, then we will first always do the semen analysis of the male. If they have given you in the history that, okay, the male has a children from another marriage, he had children, but now from this marriage, they do not have any children, then we have to look for the female factors. If no history is given for the male and the female fulfilling this criteria, first thing is semen analysis. And what is this criteria? When will the investigation begin? If less than 35 years, the couple is coming less than 35 years, and they have tried to conceive unprotected intercourse for 1 year, then we will look into the investigations and treat them. If it is, they are after 6 months of marriage, they are coming and they are 30 years old couple, 34 years. No, we will wait. We will tell them, no, we have to wait for another 6 months. So just keep on trying. And even after 6 months, if you do not conceive, then come back, because mostly 90% of the cases, they do conceive within 1 year. Okay. So remember this age, 30 to 35 to 40 after 6 months. So it's a married couple coming after 6 months of unprotected intercourse, were not able to conceive. We will start the investigation. Above 40 years, immediately. So just remember this age criteria and treat accordingly. Then for the investigations, what will be according to the history and the physical examination, the investigation we will do. If she's giving us some symptoms of PCOS, then what will we do? We will do testosterone, FSH, LH levels, giving us the symptoms of fibroids. Then we will, after bimanual, we will go to the ultrasound. She's giving us some symptoms of hyperprolactinemia. Then MRI, prolactin levels, giving us the symptoms of thyroid. Maybe she's hypothyroid, she's obese, she has some other problems, weight gain, constipation, dry skin. Then we will do these. So depending upon the symptom presentation, we have to do these. They will give you the symptoms of any one of these conditions. They will just not leave you like that, okay, a couple is coming and that there's nothing. Because if they're not giving you any scenario, then in the CDM, if all of these options are there, you will choose all of these. Okay, remember that. But if they are just giving you the symptoms of PCOS, and in the CDM, you have all these hormones, some other investigations also. So what is the one test we will choose? We will choose the testosterone one. Okay. Similarly, if there are some tubal factors, we will do the dye test. They come afterwards. Then for the lifestyle modification, if she's smoking, she uses some drugs, she uses alcohol, we have to counsel the patient about to quit them or reduce them. And for a healthy diet, start them on folic acid, regular exercise. According to the condition, the treatment will change. Okay, so if she is some PCOS, what are we giving her? Clomiphene citrate, letrozole, either of these along with metformin. If there is some tumor, then bromocriptine, carbamazepine. Similarly, if she has a history of recurrent abortions and on the blood test and other history, we find out, okay, she has antiphospholipid syndrome. So we have to start her on anticoagulants and aspirin. If thyroid problem, we have to treat for the thyroid. Don't need to remember these. They will not ask you these. Yes, for male factors, what we're doing, semen analysis. Okay. Then PCOS. What are the clinical features? A young female, obese, adolescent in her 18, like in her teens, or even after, like in her 20s, she's coming with signs of hirsutism, acne, any irregular menses or a heavy menstrual cycle, obese, hair loss. What do we have to do? Investigate first for PCOS. The symptoms are there, so we have to investigate her for that. What are the diagnostic criteria? Any two of the three are fulfilled. Oligomenorrhea, irregular menses for 6 months. Hyperandrogenism, that is clinical evidence of hirsutism or acne. Then raised free testosterone, and on ultrasound, we will have a pearl-like appearance. So these are the, if any two are present, she's coming with oligomenorrhea, and along with that, she has raised free testosterone. Okay, so it is confirmed. Even if you don't do the ultrasound, two are fulfilled, okay, we will treat her according to PCOS. Then what are the investigations? They are coming. We have to assess their BM because they mostly will be obese. We have to check their blood pressure. We have to check their lipid profile. We have to check their the glucose levels, because there is increased risk of diabetes in them. We will screen them for this diabetes also. So if they give a scenario for that a patient with PCOS is coming to you now after the treatment, what will you screen her for? We will screen her for diabetes. We can screen her for depression. So remember, according to the, like she's obese, she's infertile, she has some hirsutism, it can lead in females to depression, some psychological problems. So we do have to screen them for that also. Then obesity, we have to screen them because it is a risk factor for that. What are the investigations we are doing? Prolactin, TSH, free T4. If they give you in a scenario that LH-FSH ratio is more than 2:1, 2 LH and 1 FSH, then it is PCOS. What is the treatment? We'll treat them first with lifestyle modification, reduce weight, proper exercise. For diabetes, avoid all the sugary stuff, all the fat stuff, avoid them, control your BMI. Then we will start with either OCPs or IUS, anyone depending on the patient preferences and the underlying conditions. If increased bleeding, then we can give tranexamic acid. If they have diabetes, not even if they don't have diabetes, we do start them on metformin. Okay, because if they are trying to conceive, even then, or to protect as a prophylactically, also metformin is given because it helps them in getting pregnant. So if they are infertile, what will we do? We'll give them letrozole or clomifene along with metformin. If they're asking you for the two medications will be either of these along with metformin if the patient wants to conceive. Okay. Then for the hirsutism, it can be any laser treatments. We can give them anti-androgens like any spironolactone, any yasmin, all of this. Next is the infections. Physiological discharge, it is clear, white, flocculent, odorless discharge, pH is 3.8 to 4.2. Okay. And in these conditions, pregnancy, OCP's patient is taken, mid-cycle, PCOS, menarche, it increases. They may give you a scenario in which they're telling a female comes to you with a complaint of increased discharge on the 14th day or after 2 weeks of a menstrual cycle. And she says that it gets really high and it's really bothersome for me. So what is it? It is mostly physiological discharge. What it will be the treatment? Just counsel her, tell her it may be, it's a sign of ovulation. And if it is disturbing you, you can use panty liners. We won't just start all the investigations on her, okay? Similarly, the prepubertal vulvovaginitis. What can they give you? Young girl presenting with irritation, pruritus, mother bringing her in with discharge, any erythema, bleeding. So first, always we have to rule out any abuse, okay? Any STIs. If there is STIs, then always rule out abuse in prepubertal young children, girls. Other than that, what can be the most common causes? These three. Either it can be pinworm infection, it can be lichen sclerosis or foreign body. What is pinworm? She will come with the complaint of anal itching or pruritus, especially at night. So what do we do for that? We do a cellophane test. And treatment is mebendazole. Then for lichen sclerosis, due to decreased estrogen levels, what happens? There's thinning of the skin and white area of white patches around the labias. And they will show you they will tell that on inspection, it was like a figure of 8. So what are we giving them? Topical steroid creams. Similarly, for foreign body, careful examination with or without sedation. And never do a speculum examination in a prepubertal girl. Okay, it's a contraindication. So we will do a careful examination with or without sedation. Mostly it will be some, it can be some toilet paper, toilet tissue that is there, and we just have to irrigate the vagina with a lot of saline to remove it. Okay, we're not using any other techniques. So we'll just irrigate it and it will be removed. And we will counsel the mother about not using this a lot of tissue paper, or counseling them about the hygiene to wipe after when using the toilet, wipe it from front to back, all these things. Avoid use cotton underwears. you counsel them about these things. If there's any infectious cause, any STI, give the antibiotics, notify the public health, CAS, because then at that case, it has to be some abuse. So we have to notify it. Okay, in this table, you need to know that the pH value, it is wrong. Okay. It's for candidiasis, it should be between 4 to 4.5. If it is that, it is mostly candidiasis. The pH value is this. For bacterial vaginosis and trichomoniasis, if it is more than 4.5 or equal to 4, then it can be like for both of these, the pH value is more than or equal to 4.5. Okay, so this, I think this may be some printing issue or something, but it is wrong. So just correct it in your notebooks. Then in elder females, what can we have? Infectious causes, it can be candidiasis, it can be bacterial vaginosis or trichomoniasis. Candidiasis, most common causes, Candida albicans, mostly in immunosuppressant females. Okay, even in vaginal one, of course, it will be female, but immunosuppressant, even if somebody has HIV, some other male with some immunosuppression, they can have some candidiasis in their mouth or throat. So it is very common in immunosuppressant patients. So she might be diabetic, she might have some AIDS, might recent antibiotic use, might be pregnant or using OCPs, can be on long-term steroids. So any of these conditions can present with vaginal candidiasis. They will have a whitish cottage cheese appearance and intense pruritus, swollen inflamed genitals, vulvar burning. Then vulval burning, dysuria and dyspareunia. Saline wet mount we will do. And on that, what we will see hyphae and spores. Then the treatment. The treatment will be clotrimazole, butoconazole, miconazole, turconazole, suppositories, and creams. And in pregnancy, what are we giving? We are giving vaginal treatment. If she has candidiasis and she is a pregnant lady, we are only giving her vaginal treatment, vaginal suppositories. But if she's not pregnant, then we can give her oral dose of fluconazole, a single dose. Okay. And it is not a sexually transmitted disease. We will not treat the partner. We will not notify the public health in candidiasis. We have bacterial vaginosis. Most common causes Gardnerella vaginalis. Risk factors are high frequency of vaginal intercourse, smoking, and douching. Discharge is gray, thin, diffuse, fishy odor. They will give you in the scenario that a woman is presenting to you with increased discharge, which is very watery, especially after intercourse, and has a particular smell. They might just not write fishy, okay? But if they're giving you after, especially after coitus, and has it is very thin or watery, they might not even write gray. Okay, thin, watery, has a specific odor, and increases after intercourse. So it is bacterial vaginosis. Consider that in mind. Now, in bacterial vaginosis, when we are doing saline wet mount, what do we see? We see clue cells. Okay, clue cells are seen in wet mount. But when we are doing the whiff test, what do we have? We have fishy odor. So these two are two different tests, and we have two different findings for them. Okay. So whiff test, fishy odor, and wet mount. In this, we have clue cells. If they are non-pregnant, they are asymptomatic, we do not treat them. If they are pregnant, are coming to you with severe symptoms, then we have to treat them with metronidazole. In pregnancy, what can be the complications? Recurrent, preterm labor, preterm birth, postpartum endometritis. Then for trichomoniasis, sexual transmission, we will treat the partner and we will notify the public health also. So, but mainly we should know that in trichomoniasis, we are treating the partner. Then what is the color? It is yellow-green, malodorous, and diffuse and frothy. Remember the word frothy. And strawberry cervix. Here we have petechia on the vagina and cervix. Just write in Google strawberry cervix, and you can see the images. It will give you lots of images of strawberry, the red petechiae on the cervix and vagina. That is strawberry cervix, and it is common in trichomoniasis. They might just give you a picture of strawberry cervix and ask you what is the treatment. So the treatment is metronidazole. Okay. And in the wet mount, what do we see? We see flagellated organism. Remember, for each of them, you should know on wet mount, what do we see? They can give you a question in which a young female is presenting to you with a history of some discharge, no description of the discharge, and they just tell you that now we performed the wet mount, and on wet mount, there were hyphae. So what are hyphae in? Candidiasis. On wet mount, there were clue cells. So what are clue cells in? Bacterial vaginosis. Flagellated organism. We could only see motile flagellated organisms in the wet mount. There was nothing else. So it is trichomoniasis. So you know these things also. Treatment, even if asymptomatic, we have to treat them because it is sexually transmitted. So we have to treat the partner also, and we have to treat the patient also. And we are giving them metronidazole. Then the STIs, I think we covered, yes, we did this chlamydia and gonorrhea in family medicine. There's just, there's nothing different over here that we need to cover. Okay. Just for the screening, remember that any like sexually active female, if they are coming to us, and they are, even for male, it is the same. Less than 25 years, we have to do their annual screening for chlamydia and gonorrhea. Okay. Sexually active, less than 25, annual screening. And then what other screening we are doing for this? During pregnancy, we are screening asymptomatic sexually active people under 25 years, neonates born to mother with chlamydia, and any other people with risk factors for STIs or blood-borne infection. Rest, we did it all in the family medicine. So HPV, you should know that, remember, I remembered it like this, that the low one, 6 and 11, what are they doing? They're giving you the warts. But the more higher they are, the more dangerous they are. So 16 and 18, what are they doing? They are giving you cancer. So the lesser numbers, 6 and 11 warts, they're responsible for the warts, and 16 and 18 are oncogenic. What is the treatment? The patient may be asymptomatic, nothing, no symptoms, just on pap test, abnormal findings, and then when you further proceed to the colposcopy, you might find she's HPV positive. Or they might come to you with wart-like lesions, okay, in their anal area, in their vulvar area. So what will we do? We will treat them. For the warts, we are giving them podophylox, imipridone, trichloroacetic acid. So all of these are the treatment for the warts. And or we can do the cryotherapy. Just remember these names: podophylox, imiquimod, trichloroacetic acid, bichloroacetic acid. And these two, what is referred in pregnancy for the warts is TCA and BCA. Okay. So these are given in pregnancy. Otherwise, if not pregnant, we can give them also this, or cryotherapy can be done. If on the pap test it is abnormal, then we have to move to the colposcopy and the further testing. How do we prevent HPV? There can be a question that, okay, the patient is presenting with all the symptoms, she has HPV is confirmed. How we could have prevented it? Or in the young patient, in adolescents, in teenagers, how can we prevent it? So we can prevent it with vaccinations, regular vaccinations. And the herpes simplex, we also covered this in family medicine. Yes, I covered the treatment. Syphilis, we covered there. Yes, the screening test for syphilis is VDRL, RPR. If the screening test is positive, then the diagnostic test is microscopy, dark field microscopy. I even told you that if there's neurosyphilis, we treat with aqueous penicillin. Otherwise, we are just giving IM single dose. But in neurosyphilis, only in nurse, we have giving IV aqueous penicillin G. Okay. Next, we have Bartholin gland abscess. female coming to you, maybe she's panicked, or maybe just coming to you, the doctor, I was peeing and I noticed some cyst in my vulvar area. What could it be? So on inspection, when you check, it is a Bartholin gland. What is it? Unilateral swelling and pain in the inferior lateral opening in the vagina. Sitting and walking may be difficult or painful. So she can have these symptoms. She might not have these symptoms. It depends. If it is an abscess, of course, she will have like she may have pain and all these symptoms, but just a gland and swollen and just a cyst, so she might not. And if it is recurrent, what are we using? We are using word catheter, marsupialization with word catheter, if it's recurrent. Otherwise, first line treatment is incision and drainage under local. Whenever there is an abscess, any part of the body, there is an abscess, what do? We incise and drain it, incision and drain it. And if there are antibiotics have to be given, we give the antibiotics. But for abscess, any part of the body, always remember incision and drainage has to be done. If it is small, not interfering that much, then after incision and drainage, we do sitz bath, warm compresses. Then we have PID. So let me check the time. Okay. In PID, did we cover it? No, we didn't. Okay, so any woman presenting to you with a history of recurrent STIs, or previously she had STI and now she's presenting with fever, and she had some vaginal discharge and now she's presenting with fever and lower abdominal pain. Most probably it is PID and we have to treat her like PID. Okay, they give you a scenario. A woman, she came to you last week, a lady with vaginal discharge, dysuria, you gave her antibiotic for it, treated, and now she's presenting with lower abdominal pain and fever. So what is it? Think about PID. Okay, inflammation of the upper genital tract above the cervix, including endometrium, fallopian tubes, ovaries, pelvic peritoneum, contiguous structures that primarily affect young sexually active women. What are the etiologies? Chlamydia, gonorrhea, and then E. coli, M. genitalium, different, but most common causes are chlamydia and gonorrhea, or it can be E. coli. In rare cases of PID, E. coli is formed. Okay, then the risk factors are age, 15 to 25 years, multiple partners, STI, previous PID, and IUD. Okay, so these are the risk factors. If any of this is present, we have to think towards PID also. What are the clinical features? These clinical diagnosis of PID is when do we diagnose it clinically? Fever, lower abdominal pain, tenderness, abnormal discharge, cervical or vaginal. Okay. What are the investigations? Blood work, because she's presenting to you with lower abdominal pain, right? So we always have to do beta HCG. So first beta HCG, negative, then along with it, urine routine and microscopy, speculum examination, bimanual examination, looking for any doing the vaginal swab, cervical swab, according to the history, nucleic acid amplification testing, HIV, syphilis testing. Then ultrasound. On ultrasound, what do we see? We see maybe normal fluid in cul-de-sac, maybe there's an abscess. If there's an abscess, we have to drain it. Okay. And it is the laparoscopy is the gold standard, but it is just the last resort. We don't just jump to the laparoscopy. Treatment is antibiotics, abscess is present, then drain it under the ultrasound guidance. Okay, if there is, the patient was on IUD, she had IUD and now she's presenting with symptoms of PID. What will we do? We will first treat her with antibiotics for 24 hours. After 24 hours of treatment, then we will remove the IUD. We won't immediately remove the IUD. Remember that we started her on antibiotics. Now, after 24 hours, when they ask us, when are we removing the IUD? We are removing it after 24 hours of the IUD insertion. There can be chances of perforation. So first treat it, control it, and then remove the IUD. Antibiotic treatment, mostly the same is used as we do for chlamydia, gonorrhea, that is ceftriaxone and doxycycline. If treating them inpatient, so instead of ceftriaxone, you can also give cefoxitin and doxycycline. Okay. What are the complications? It can be chronic pelvic pain, persistent hydrocephalus, abscess, peritonitis, adhesion formation, infertility, ectopic pregnancy, bacteremia, and septic arthritis. Okay. Then we have toxic shock syndrome. And toxic shock syndrome, they will give you a scenario that a female is presenting to you with high-grade fever, hypovolemia, chills, and she is on her menstrual cycle and uses tampons. Okay, so what is the most common cause? Uh, uh, what is the most common thing that should come in our mind is toxic shock syndrome. Okay, and what are the clinical signs? Characterized by rapid onset of fever, rash, hypotension, multi-organ system involvement, any tampon use, any maybe some packing is done for some epistaxis. So any foreign bodies present in the body, so we have to rule that out. And first step will be to remove the foreign body. Okay, then we will give her antibiotics. If she's hypovolemic, resuscitate with fluids, antipyretics for female. First, remove the foreign body. So, sudden high-grade fever, chills, sore throat, headache, diarrhea, macular erythroderma, any rash she can present with, signs of multi-system organ failure. Take a proper history, the symptoms are present, treat the shock, replace fluids, antipyretics, and remove the foreign body. First line treatment will be remove the foreign body. If they are giving you a history of foreign body, remove it first. Then surgical debridement, if needed, adequate hydration and antibiotics are vancomycin, clindamycin, and piperacillin tazobactam. Whenever we use piperacillin tazobactam, whenever there is some, these are all broad spectrum, okay? So mostly any foreign body, anything from outside affecting the body, we use piperacillin tazobactam. Then after this is not, we have covered what are the causes of dyspareunia and then treat the underlying cause, and any counseling. If there's no cause, just counsel her, give her SSRIs. That's it. Now, next is menopause. Just let me pause the record.